My topic today is asthma in the elderly, and in fact currently people are quite interested in the idea that asthma exists in various phenotypes, that it's a heterogeneous disease, and the notion that asthma in the elderly might be a phenotype has emerged in the literature, although I think, as you will see from what I have to say, that it is part of a continuum and not a distinct entity in its own right. So, you know, asthma, first of all, it's important to realize, occurs throughout life, and I think we sometimes forget that asthma can occur in elderly. I haven't defined for you what elderly is because it's becoming a sensitive issue for myself at this point. It's like middle age. We always said middle age was 10 years older than you are, but so in this case I'll say that elderly is 10 years older than I am. There's a trend actually for an increase in incidence of asthma with age. The 5-year incidence of newly diagnosed asthma in adults over 65 is estimated to be about 1 in 1,000. Clearly it's underdiagnosed in the elderly, where we tend to suspect other problems, and it can on occasions have overlapping features with chronic obstructive pulmonary disease. But of particular interest, the mortality from this disease continues to be high. Now, a major issue, in fact, is that asthma is superimposed on an aging respiratory system. And so some of the effects of age can have profound effects on the clinical manifestations of asthma. So here in the first panel on the left, we're looking at the elastic properties of the lung. This is lung volume, and this is the pressure, transpulmonary pressure across the lung. And as you go from younger age to older age, there's a progressive loss in the elasticity of the lungs. So in a sense, this is a characteristic that is reminiscent of the changes you expect with COPD or with emphysema. On the other hand, the rib cage becomes stiffer, so this is compliance of the rib cage. It comes down with age. The overall chest wall compliance comes down. And of course, the chest wall is made up of rib cage and the diaphragm abdomen compartments, and this also gets a bit stiffer. So the chest wall is stiffer and the lungs are floppier. And of course, the lung parenchyma, in fact, tends to simplify. So in a very elderly individual, this is an image from a 100-year-old subject that was published recently, and it shows you a simplification of the lung architecture. The alveolar spaces are large compared to the lung parenchyma of the young adult. Now, of course, if you have an increase in airspace size, you will have less air-liquid interface surface. Therefore, you will have a loss of a lung recoil. And this has effects on lung volume, for example. Here we have the typical representation of lung volume with tidal volume, total lung capacity, functional residual capacity, and the residual volume. So with age, the residual volume rises and is a reflection of progressive air trapping. The FRC goes up a little bit, not too much, and total lung capacity doesn't change very much. Now, the change in lung elastic recoil has an immediate impact on the expiratory flows from the lungs of older subjects. Here you have the flow volume curve from a young subject showing you a nice linear descent during expiration. The older subject has this typical concave upwards scooped flow volume curve indicating that there's obstruction. And of course, the FEV1, FVC over time declines as a function of age. Now this shows you the effects of age on the FEV1, and the red line here is for healthy non-asthmatic, non-smoking subjects. Of course, there's a decline in the FEV1 with age. Then if individuals smoke, there's on average an accelerated decline. Subjects with asthma have lower lung function, and this is the trajectory if they don't smoke. But if they smoke, the lung function or the FEV1 will be expected to decline more rapidly. Now, it's curious that the prevalence of smoking among asthmatics is actually very similar in most studies to the general population. So even though they have a lung disease, they don't necessarily adjust their smoking habits. There are also effects on the immunology, in particular in relationship to IgE, and therefore this would make you wonder about the role of allergy and atopy as a function of age in asthma. What we can see here is that in fact males have and females have declining IgE over time. However, if one looks at asthmatics, the asthmatics will in general have elevated IgE when it's corrected for age, so that they're more likely to have an elevated IgE if they are asthmatic. So this has led to the idea that in a sense the old notion of intrinsic asthma being associated with older age and extrinsic asthma being a disease of the young doesn't seem to hold true, but in fact we have a continuum of the immune processes as well across age. Now, and this is just to show that if subjects have a high IgE, that this is associated with the FEV1 FVC ratio. So these are never smokers and these are current smokers. Non-asthmatics have a FEV1 FVC that is higher obviously than the asthmatics. And whether they have a high IgE or a low IgE doesn't make much of a difference. But if they're asthmatic, the low IgE ones have better lung function than those that have high IgE, suggesting that it has a role still across the ages, right up into the elderly age bracket as well. Now, people have tried to look for distinct clinical asthma phenotypes, and cluster analysis has been applied and published. And this cluster analysis, which was done from a primary care asthma cohort plus a secondary care asthma cohort from Britain, identified two groups that were later onset asthma: the obese, non-eosinophilic, largely female, and then there was also a late onset male group, largely male group. And the differences were that the obese female predominant group had a lot of symptoms, but not too much airway inflammation as reflected by eosinophilia in the sputum, whereas the males had a very inflammation predominant disease, but not too many symptoms. But there is not a clear evidence that elderly asthmatics fall out as a distinct population or subgroup phenotype of asthma. So the males had mainly had few daily symptoms and very active airway inflammation. And if they had a lot of sputum eosinophilia, it was associated with frequent asthma episodes, symptoms, and also exacerbations, often associated with chronic rhinosinusitis, nasal polyps, and in some cases aspirin sensitivity, and poorer lung function. So that's that sort of male group. Then there was the obese female group, predominant group, with less atopy, but requiring a lot of healthcare utilization because of the symptoms associated. A tendency to use a lot of medications as well. Now, a second phenotype clustering exercise was published from the States looking at severe asthmatics, and here they actually divided up their asthmatics on the basis of lung function, pre and post bronchodilator, and the age of onset of the disease. So there were very few criteria used to actually distinguish these clusters. And they did find that they had two clusters that seemed to be distinguished on the basis of age, one under 40 and one over 40. But they weren't the most severe clusters of disease. The severer clusters tended to be clusters 4 and 5. So again, not a strong relationship between the age of onset of disease and the behavior clinically. Now, there's been some attention to the issue of inflammation in asthma at different ages, and this is shows you the different types of inflammation you can expect. First of all, you can have eosinophilic inflammation in the sputum. You can have neutrophilic inflammation. You can have a mixture of the two forms of cells, or you can have very few inflammatory cells where you have mainly macrophages present. So these have been proposed as being different sort of inflammatory phenotypes, but they don't actually relate very well to the activity of disease. And in this initial publication, it was suggested that the only factor that associated with having excess neutrophilia in particular was the older age group. So neutrophilia and neutrophilic asthma was associated with being older, and also this sort of mixed picture of eosinophils and neutrophils. But there was no association between any other characteristics of the disease. And in fact, when a subsequent study looked at the neutrophilia in the sputum of elderly asthmatics, they found that in fact there was no difference between healthy, a sort of mild asthma and healthy elderly individuals in terms of sputum neutrophilia. So in fact the suggestion that neutrophils were associated with older asthma was based on an observation that didn't actually look at the normal population. So as you get older, you have more neutrophils in your sputum. And here this sort of shows you that there are trends over time from young asthmatics to middle age to elderly in the distribution of the inflammatory cells in the sputum, in that in the older subjects there is less eosinophilic asthma compared to the young subjects, and there is an increase in the proportion of neutrophils in the sputum. So there is a bit of a shift in the inflammation, but it's not that striking. And this shows you that if you look at elderly asthmatics only, and you now look at them as either severe, moderate, or mild, you can see the severes up top here. Very few of them have very little inflammation. So the dominant phenomenon is that there are neutrophils, eosinophils, or mixed inflammation in the severe asthmatics among the elderly. So it tends to be richly inflammatory, whereas in younger subjects you have categories of individuals that have very little inflammation but have a lot of disease, presumably more reactive smooth muscle. So we had our own asthma cohort, which we call the difficult to treat asthma cohort, and we had about 70 severe patients and 34 moderate patients. And we observed them over 1 year of time. So this is an observational study, and we measured a variety of outcomes on these patients. We assessed their lung function, we assessed sputum inflammation, and we follow them monthly if they were severe, and we saw them every 3 months if they were moderate. Now, as you can imagine, the age actually spanned from young subjects to subjects that were over 75, and they were slightly older in the severe group than in the moderate group. Age of onset of disease was actually fairly similar. Sex distribution was a little bit different, but this just depends on how you select your subjects. No difference in obesity rates. The ex-smokers were actually more in the moderates than in the severes, so the severes seem to have avoided smoking earlier on. Lung function was worse, with an FEV1 of about 65% in the severes. The ratio was obstructive, and there were some differences in atopy. There was slightly less atopy in the severes, very high rates, like 91% in the moderates. So we looked at things as a function of age. So these are not the loveliest of graphs, but you can see every single subject and every single measurement of FEV1 for those subjects over time. So that we're looking at the age of the subjects here and the dependence of the FEV1 on age. And you can see that there is a slight downward trend which reaches statistical significance, but it's not very strong. When we looked at other things like sputum eosinophils, for example, we didn't find any relationship. There's a very mixed picture of sputum eosinophilia as a function of age. Likewise, we did not find the expected increase in neutrophils. There were subjects that could have almost 100% of neutrophils, whether they were young or old, in their sputum. The asthma control questionnaire was also not significantly related to age, so that subjects were just as severe young as they were old in this particular cohort. Nitric oxide also didn't vary. It was elevated in these subjects, exhaled nitric oxide, but it didn't change with age, and there are other studies that have shown that as well. The probability of developing an exacerbation of asthma as a function of age was also not significant, so that the likelihood of exacerbation did not increase in our subjects with age. So in a sense, it doesn't seem like there's a distinct entity of asthma in the elderly. It's just simply part of the spectrum. And young asthmatics do eventually become old asthmatics, and it still seems to be rather, the disease seems to be pretty much the same. However, there are common comorbidities that one needs to consider. For example, obesity tends to increase, and this leads to more symptoms and more impairment, even if there is no actual worsening of the intrinsic underlying process. Simply breathing at a lower lung volume because of obesity and also carrying the weight around will increase symptoms of dyspnea, and will increase airway narrowing in those subjects. We also know that obstructive sleep apnea increases with age, and we know, of course, that it increases with asthma. So in asthmatics, particularly those that have a lot of upper airway disease, we can anticipate a very high rate of obstructive sleep apnea, so we should give this some consideration. If individuals have symptomatic gastroesophageal reflux disease, then this, of course, may also be making things a little bit worse, although there's not a strong relationship between this phenomenon and the activity of disease in general. However, a lot of older subjects are now at the extreme of age when we're talking about subjects that are asthmatic and are in their 80s or approaching 90, as we do have them. Problems with swallowing and recurrent aspiration start to be important, and this is something that we also need to be mindful of, as we can treat the asthma very vigorously, but in fact the individuals are actually suffering from aspiration, mucus hypersecretion, etc. from this phenomenon. Then, of course, there are drugs that are given to older people that can have effects. For example, administration of beta blockers to individuals with glaucoma can be problematic, even though you might think that this would not make asthma worse. It certainly can do. And prostaglandins are a preferred drug in this, under these circumstances. Of course, paroxysmal atrial fibrillation is extremely common and increasing in prevalence, and cardiologists happily give non-selective, they give Sotalol, which is relatively non-selective and causes problems for us because we cannot convince them necessarily to remove the drug, but this can certainly worsen the disease. So we have to be aware that concomitant drugs may be a problem for us. If patients develop cognitive impairment, it can be very difficult to really know whether they're adherent to their medication. And this, of course, is something that we need to assess. And we may need the help of a family member, for example, to make sure that the medications are taken on a regular basis. Now, other points, I think, that are of importance to stress in relationship to asthma in the elderly are that we need to use objective evidence to confirm asthma. So there's a tendency to call individuals that are older and have symptoms of obstructive lung disease, to call them COPD, and dismiss the diagnosis at that. And this sometimes leads to under-medication, particularly the failure to give appropriate inhaled corticosteroid therapy. I've mentioned the issue of comorbidities and their importance and the adverse effects of treatment for these comorbidities. Of course, also we have to balance our treatment with the adverse effects. For example, the use of very high-dose steroids in very elderly asthmatics is certainly something that has to be done carefully because it can lead to adverse effects on mentation and also to mood changes and sometimes even psychosis. Subjects that have cognitive impairment, of course, will pose a problem in terms of adherence to medication. Now, manual dexterity, also the ability to use the inhaler devices, is an issue, and this needs to be checked very carefully. And it's interesting in that regard that there are demonstrated high failure rates for the use of dry powder inhalers with elderly asthmatics. The other issue, of course, is polypharmacy. So when individuals have 20 medications that they've been given, then the likelihood that they will not take their respiratory medication increases, despite the fact that it's simply inhaled rather than tablet form. So I would conclude by saying that asthma certainly occurs de novo at all ages, and we have to obviously get that message out there, so we should not be surprised if an individual develops asthma at the age of 65 or 70. Patients themselves are often surprised because they believe that, of course, it's a heritable disease, so why would they develop asthma at older age? Clearly, it seems to be triggered by the development of severe respiratory viral infections. Now, the immune basis actually may be different, and the studies have been done not in the very elderly, but in late onset asthma, but at a younger age, showing that the eosinophilic inflammation seems to be less dependent on T lymphocyte infiltration of the airways. So there may be some fundamental differences, but the treatment remains the same as the treatment for asthma at all other ages. Education of the patient, it may be more difficult and will require repeated sessions. Written action plans are particularly important because older individuals often will not take possession of their disease. If you tell them to take X or Y medication when they have this or that problem, sometimes it's a little confusing for them and it needs to be written down so they understand it. And of course, they may need support from the medical team, particularly if you have asthma educators or nurses that help you with your medical practice. This is very, very useful, so they can be in touch with the patients. And of course, sometimes you may need to educate a family member who will then make sure that the patient is taking the appropriate medications. So I will stop there and thank you very much for your attention.